Wild Health is about optimizing you. We use genomics, blood work, biometrics, microbiome assessment, many other tests, and a conversation with you to come up with a full health optimization plan. What's the perfect diet, exercise, and supplement plan for you and only you? The Wild Health podcast is about optimizing all of us. Here we cover the cutting-edge science that gives you the base to be able to apply the personalized plan we give you as a patient. To sign up as a patient, go to wildhealth.com. Or if you're a physician or health coach and you want to learn how to do this for your patients, we're happy to help as well. wildhealth.com for all the information on becoming a patient or working with us.
Hi, everybody. It's Mike. Just wanted to give a quick warning about this episode. So this podcast episode contains a discussion including sensitive topics related to PTSD, mental health, and suicide. Our discussion touches on personal perspective and experiences and some emotional content. Listener discretion is advised. If you or someone you know is struggling with these issues, please seek professional help and or contact the National Suicide Prevention Lifeline at 988 or 988lifeline.org. We are gathered here today with Kristin Dawson, Dr. Kristin Dawson, Ben Askins, Doc Ben Askins, honorarial, and myself to chat about a really interesting study. I would say that. I would say it's a really interesting study. I might use air quotes around the study word in really interesting study, but this is, like most early research, it's inspirational, hypothesis generating, stimulating to talk about. So let's just get into it. This is from the Journal of Military Psychology. And thank you, Ben, for bringing this to us, because not a journal that's on my radar. Prospective associations of psychedelic treatment for co-occurring alcohol misuse and post-traumatic stress symptoms among United States Special Operations Forces veterans. So, long story short, they are looking at the use of two different psychedelic substances in a population of 86 Special Operations Forces veterans. This was a multi-center study, but the treatment was performed in Mexico. And the two psychedelic agents that they were investigating were Ibogaine and 5-MeO-DMT, or for those scientists in the crowd, 5-methoxy-N-N-dimethyltryptamine, which is why people call it 5-MeO-DMT. This is like razor edge stuff, Kristin, from a psychiatry standpoint, don't you think? I mean, I don't know that I was able to find more than 10 articles in Humans looking at 5-MeO-DMT use in a therapeutic setting, and then Iboga, lots of, word of mouth stuff around it as an addiction treatment, and there's definitely a lot of buzz. But why don't we start with you, Kristin? What's your reaction to just sort of where this fits in the landscape of psychedelic therapy in the space of modern psychiatry?
Oh my goodness.
Small question.
That's a small question. You don't, wow. Okay. So I think perhaps this would be better for Ben, who brought this article to our attention. However, Ben and I had recently been interested in Ibogaine and simply what was out there in terms of literature. And you're right, there's not a lot of clinical research related to Ibogaine that we can turn to, at least in peer-reviewed journals. And so I would say that there is a lot of interest in its anti-addictive properties, and there has been a lot of interest in the last, Ben, 100 years. At least that's the number I'm thinking of. It's been around for since 1936, I think. But certainly this is not at all standard of care. This is not something that we are, in the United States at least, ready to offer patients. It's very interesting. We're seeing some analog studies of Ibogaine in psychiatry. But I think what you mentioned first is that this is probably a jumping off place to start the query and to start to understand the properties of these two substances, and what their potential risks and benefits might be. And the reason why this study was, performed in Mexico is because it's not a scheduled, neither 5-MeO-DMT or Ibogaine are not scheduled medications in that country, and so that was a place where it can legally be administered. And so the studies that we have are probably going to come out of places where that's the case. So I guess that's my initial disclaimer. Ben, what would you say to that?
Kristin, I think it was you that was telling me that previously the prescription name of Ibogaine was Endabuse, one of those, clever pharma names for a medication where they're trying to embed in there what it's for, and had been used prior to sort of, the war on drugs period for opioid and alcohol withdrawal. Am I remembering that correctly?
You are. Yeah, and it has been studied in this country, but that body of work was shut down. I think it was NIMH was looking at opioid withdrawal treatment options with Ibogaine, but it was shut down due to concerns about the cardiotoxicity and neurotoxicity of Ibogaine.
Yeah, Ibogaine's known to cause QT prolongation and ventricular fibrillation in a percentage of, ostensibly healthy patients as far as we can tell, right? So there's some risks associated with the medicine. I think I emailed you guys earlier in the week. I skimmed over the paper. So a friend sent me the paper in the veteran community, asked, hey, what do you think of this? Mm-hmm. And yeah, I'll take a look. And I think I emailed you guys and said, I think it's a really boring study in terms of, from a clinical perspective, this is a prospective, observational, single-arm trial that's, essentially a compendium of case studies as far as the powering of the study goes. Like maybe there's a little signal over noise here to try to follow, but this isn't, gold standard randomized controlled trials with, large powered patient populations in the study or anything along those lines. So I read it over and said, maybe we could talk about it on the podcast. Seems like it's kind of boring. You read between the lines a little bit, and it's, people go into a clinic in Mexico to seek treatment with toad venom and Ibogaine extract from, psychedelic trees in West Africa, which, is kind of a headline promoting sort of way of running a trial in the first place. But I really wasn't impressed with it on first reading. It's novel molecules. There's not a lot of data on 5-MeO-DMT and Ibogaine in alcohol abuse and in PTSD at this point. So the fact that it's a publication about something that's, like you said, on the bleeding edge of the literature makes it a little bit interesting, right? And then I read it over again this morning and started thinking that there's a lot more going on with this study than meets the eye from taking off my clinician hat and trying to think through everything that's going on there. Clinical research is something that we do. We inherited the empiricism tradition from the Enlightenment, and we do this iterative, inductive reasoning sort of process is how clinical trials are developed, where you do the literature research, you design an experiment, you conduct the experiment, you collect the data, you interpret the data, you peer review it, you see if you can publish it, and then you start all over again, baby steps with 95% confidence if you're lucky on what the outcomes are. And it's all very probabilistic sorts of reasoning, right? But the general population and public policy in particular tends to be on the other side of the Enlightenment, with the rationalist perspective using deductive reasoning about what the letter of the law says, around what you can and can't do and what is and isn't true with, 100% certainty if your reasoning is done properly, right? That's the promise anyway. And as I started to look at the paper a little bit further, I think it's kind of a Trojan horse, maybe a little bit, like that this might be aimed more at public policy influence rather than clinical research influence, if you catch my drift. It's like, like the old way of reasoning was all men are mortal, Socrates is a man, therefore Socrates is mortal, right? That's the deductive reasoning paradigm. An old, like World War II war posters used what was called an enthymeme. Are you guys familiar with enthymemes?
No.
We are not.
So, yeah, an enthymeme is used in advertising and marketing, and it's a way of using logic but drawing in your audience to supply some of the premises or some of the conclusions. So instead of saying all men are mortal, Socrates is a man, therefore Socrates is mortal, you say all men are mortal, Socrates is mortal. Because everybody already knows he's a man, right? They leave that out and they draw the audience in. Like, I was looking at old enthymeme posters in World War II. These are like the original memes. They were memes before they were memes. They're trying to persuade people not to use extra gasoline during World War II, because every drop of gas we use here in the homeland is a drop we could have sent over to the boys in Europe to power a tank. And car sharing was a really big deal. So there's this old ad that says, when you ride alone, you ride with Hitler. Join a car sharing club today. And the picture is of this like well-to-do gentleman in a convertible car top. And he has a ghost outline of Adolf Hitler riding shotgun next to him, right? So it's an enthymeme. Like the implication is, if you waste fuel, then you support the enemy is the conclusion that they're trying to drive you to without saying that explicitly, right? And I think that this study a little bit is enthymemetic. The first two paragraphs of the study just tell you about who Special Operations Forces veterans are, what it takes to be a Navy SEAL or a Green Beret in the first place, the amount of just suffering that you're willing to endure to become a member of that community, and then the tasks that are assigned to that community in the last 2 decades of warfare is just grueling. It's the environment that is the highest exposure rate for PTSD and TBI that you could possibly imagine, is essentially what they're driving at in the first 2 paragraphs. And then in the second 2 paragraphs, they do a real quick run through. It's like an academic tour de force about what the current state of affairs is in treating TBI and PTSD, and then comorbid alcohol abuse was the real target in the metrics that they're studying here, right? So they're building this enthymemetic conclusion, essentially, like, you don't even have to get down into the weeds. If you look this study up, Rutledge published it, which is like a big powerhouse academic center in jolly old England that put this out. And it's free online. It's not behind a paywall. It's in the Journal of Military Psychology, and usually you're going to have to drop $40 to get at this thing, but it's out there and you can read it yourself. You don't need to get down into the weeds on the math. If you read what the conclusion is and you read the first 4 paragraphs, you're going to get what I think they're trying to drive at here, which is that if this stuff works for this population, then it can work for anyone, is what they're getting at. By implication, not explicitly anywhere in this paper. That was my second reading of the paper that made it seem a bit less boring to me. But I'll stop there and see what you guys think about that after your readings of it.
Wow. I don't know how to follow that.
I do, Kristin.
Oh, okay.
I do.
Thank you.
I do. But if you were going to come up with something, I'd love to hear what it is, Kristin.
No, please go ahead, Mike.
Okay. All right. So, number 1, how you managed to land that plane, I have no idea, Ben, but that was unbelievable. Number two, I think we need to take one quick just step backwards. If you were inclined to believe that time was a real thing and was linear, then we probably should have started with explaining what in the heck Ibogaine and 5-MeO-DMT are. So I'll give you the quick rundown. Ibogaine, naturally occurring psychoactive substance found in the iboga plant, been used as a traditional in traditional African spiritual practices, and has been studied a lot, although not with really high quality placebo-controlled, randomized controlled type of trials, as a potential treatment for addiction, primarily due to the hallucinogenic but also introspective effects of Ibogaine. So if you want an introduction into what iboga treatment looks like, no affiliations, there's a documentary called Dosed, Dosed, about a young woman in British Columbia, in Vancouver, who's struggling with opioid addiction, and allows a documentary team to follow her around as she goes through a series of both psilocybin and Ibogaine treatments. So we learn quite a bit about iboga in that setting, and it's more fun than, I don't know, Googling or going to ChatGPT for it. So that's one way you can get a little bit deeper. And as Ben mentioned and Kristin alluded to as well, there are cardiovascular side effects to iboga. The therapeutic index for things like ketamine and things like psilocybin, there really isn't much of a cardiovascular immediate sort of physiologic risk from most of those substances. Again, like, not endorsing, and you need to be making your own risk benefit analysis. We're not giving medical advice, but Ibogaine definitely raises an eyebrow for this has to be used in a clinical setting where you've got an EKG done and cardiac monitoring, and it should be done super, super responsibly because there are real cardiovascular risks. It doesn't mean that there won't be a role for it, but something to be mindful of. 5-MeO-DMT, on the other hand, a super powerful psychedelic compound found in some plants, but it's really well known for being I think it's about 30% of the venom, it makes up 30% of the venom of Bufo alvarius toads. So this is sort of the toad venom, or the God molecule. It induces really intense spiritual experiences and is really well known for rapid onset and short duration. So you're talking onset within 2 to 5 minutes and really peak effects around 10 to 15. And then 20 minutes later, people are speaking and back down into their bodies and communicating. So a very atypical psychedelic compound as compared to things like LSD or psilocybin or MDMA, exactly. So you're looking at hours there versus minutes here. And then the one other thing about 5-MeO-DMT is it works by binding to serotonin receptors in the brain. And Ibogaine, I don't think we have quite as much understanding of the exact. First of all, we don't really have an understanding of the way that any of these reality switching compounds work, right? I mean, you're neuroplasticity, sure, that's how ketamine works, and MDA, but it doesn't really explain the shift in consciousness that people feel. So still not elucidated, but we know a bit more about 5-MeO-DMT than we know about iboga, at least in the West. And I'll stop there just to give some background for people who are like, what did they give these folks? And in the study, they gave them iboga for several days. There was journaling and introspection during the interval periods. There was therapy where they actually had talk therapy with folks. And then on the last day of their treatment at this center, they underwent a series of 5-MeO-DMT treatments. Because it's so short, those things will often look like ceremonies for 5-MeO-DMT will often look like what they did in this study. Multiple inhalations, and then it's inhaled, it's smoked. So multiple inhalations, and then periods in between, and then maybe going back in for another inhalation. So it was, I want to say, 4 days of iboga and introspective work and therapy, and then 1 day of 5-MeO-DMT. And I'll stop. I'm going to land this plane too, Kristin, and then I'm going to you. But bottom line, yes, there's no placebo arm in this trial. right? You could, if you wanted to put on a full clinician hat, you could say, well, maybe it was just all the journaling and introspection that made people get better, because we have no idea. They had all of this stuff delivered as a complete package. But alcohol abuse and misuse scores, as well as PTSD scores, basically got cut in half for the population that was treated here, and those effects seem to be sustained for several months. So I think that's where you kind of, at least I raised an eyebrow and went, this doesn't look dissimilar from MDMA in a therapeutic setting for PTSD with effects prolonged for months. MDMA may be a little bit even of a stronger effect, but again, you're seeing these really dramatic decreases, in contrast to what Ben highlighted that the authors outlined in the second few paragraphs on here's the current traditional Western model of treating PTSD and treating alcohol abuse, and guess what? It's not terribly effective if you're not incorporating some of the newer technologies. So I'll stop there, but a little bit of background for sort of what they did and what these things actually are that they gave to the participants.
Yeah, that's great, Mike. I think in the spirit of continuing to explain exactly what the study, was about, there were 86 special ops forces veterans who self-selected themselves to go to this treatment facility in Mexico, which essentially advertises itself to be specific for special forces treatment. And what's, I think, again, maybe piqued my interest, we've talked about the limitations of the study some, it is the sort of intersection of the problems that these special ops individuals presented with, because they're very difficult to manage. The sort of combination of multiple traumatic incidences resulting in probably more of a complex PTSD, a more prolonged chronic treatment-resistant PTSD clinical picture, with a co-occurring significant substance use disorder in about half of them. 45 of the 86 folks had problematic alcohol use, with, in some cases, a mild TBI that historically makes engagement in any longer term therapeutic intervention more tricky, especially anything that's cognitively focused. So any type of our psychotherapies that require maybe a sustained therapeutic intervention in terms of the 50-minute therapeutic hour and building on concepts and for a sustained period of time, that can be maybe more difficult for somebody who has the mild TBI. And then again, the veteran population for whom there may still be some significant barriers to accessing mental health care, especially stateside, interacting with the VA system, and certainly I've worked in the VA system. There is trauma around coming into a VA facility and triggers around accessing care, mental health care in a facility associated with the organization that they associate with their trauma. I guess if I'm saying that, okay. So there's stigma, there's the cognitive impairment, there's the substance use, there's the mental health, the traumatic symptoms. All of that together makes this patient population a very challenging one to reach and to have a positive effect on. So for me, yes, there's a lot going on with limitations of the study. And at the same time, one of the authors' kind of points is we need something transdiagnostic that's going to reach folks who are very difficult to reach. They're very difficult to engage in treatment for a sustained period of time. One of the benefits of this particular model is that 3 or 4 days of intervention with maybe 6 months of benefit for a percentage of them, that's a pretty impressive outcome. Again, certainly this needs to be studied, in a randomized way, in a controlled way, but at least the that part gives me some hope and some interest that we're going to continue to pull this thread. Again, just knowing clinically how challenging it can be to engage these patients, and to have as much of an effect on their symptoms that they're presenting with.
Yeah, I mean, for anyone listening who is too afraid to ask, and also it's a podcast and we can't hear you, TBI is traumatic brain injury. I know we talk about it all the time, but just in case you haven't listened to any of our prior podcasts, that's what we're talking about with TBI. Kristin, I love that perspective. I'd love to hear yours as well, Ben, particularly around the value and potential impact of a rapidly acting therapeutic modality in a patient population that's so prone to risky behavior and or suicidal ideation or suicide itself.
Yeah, I'm really grateful for that question. I'm also really grateful for you taking a little time out to explain all of the safety concerns around these particular medicines. There's a lot that we still don't know about them, and what we do know does pose some risks, right? And I think I mentioned already, like, I was kind of conflicted in thinking about this study since this morning, because I put on my clinician hat and I thought it was kind of boring because there's not a lot of like really solid data there, right? Like, we just need more data around safety and around efficacy from a clinical perspective before I'd ever even consider, recommending this as a treatment to a patient. But I take that hat off and I put on my veteran hat and I think, my friends are dying, and some slower than others, some more quickly, and there's just all this stigma surrounding even asking for help in the first place in the communities that we're talking about. And is there a way to try to bring the facts out into the daylight more quickly so that we can know what we're dealing with here and overcome all of the obstacles to reaching this patient population that Kristin's highlighting and that are highlighted in the third and fourth paragraphs of the study as well. So I just started like, how do I get the clinician hat and the veteran hat? How do I get these two halves of me to like make friends with each other, and see if we can solve this? And I'm going to say something potentially controversial. Imagine that, and then you guys can walk it back for me if you feel like that's necessary or whatever. But we're coming out of this global pandemic situation where under the Trump administration, we had Operation Warp Speed, which under the Biden administration has been changed to the White House COVID-19 response team, right? And we were able to run through a whole lot of clinical research really, really quickly in response to this global pandemic. And at the end of it, laying aside all of the cultural controversies and the conspiracy theories, and, with 95% confidence, we arrived at a vaccine that we were able to give to people safely and efficaciously on the same level as the vaccines that we give to new people on the planet within the first week or so of being here, right? And we did that in such rapid time frame, something that would have taken decades to do in the past, we managed to do in about a year or so recently in the face of this global crisis, right? And I would suggest that we've been in the global war on terrorism for 20 years now, and that it's pretty obvious to any objective observer that we have a global problem of trauma, not just an American problem, but you look in the mirror long enough and you're going to see the problem of trauma that we all deal with at some level or another. So I'm thinking, like, what is it going to take for us to get a White House trauma response team put together so that we can come up with like an Operation Ludicrous Speed and figure out the safety and the efficacy around some of these novel molecules for treating what is a global pandemic of trauma?
I'm not going to walk that back one step.
No, I think, can Ludacris be the spokesperson for this effort? Because then I am definitely
All I take away from that last 30 seconds, Ben, is that whatever project I'm working on next, I am project naming it Project Ludicrous Speed.
Right, and that's what we
Yeah.
need to do on this problem is we got to go plaid.
So true. The I just had a conversation with a integrative health physician in the Bay Area. It'll be out on the podcast maybe before this or after this, so I won't do much spoiling or explaining of it. But this same topic came up with relationship to the obesity and type 2 diabetes pandemic, right? I mean, we've got 50% of American adults who are obese and rates of diabetes that are approaching 50%. And we could turn around and create a vaccine for a deadly pandemic virus in whatever it was, less than a year, or just around a year. And we've been struggling with this not only in Western society, but worldwide for over a decade, like well over a decade. And I don't know if it's just the, you don't really notice if you're putting on a couple of pounds because you see yourself every day. But if you haven't seen somebody in a long time and they look like they've lost or gained weight or their hair's gone gray or whatever has changed about their appearance, it's super noticeable. I mean, it feels like these insidious problems that develops societally, whether it's, a sedentary lifestyle and metabolic dysfunction, or it's complex post-traumatic stress disorder in a veteran population. It's this slow roll. And I think that's my, non-evidence based, obviously just my opinion, man, is this is probably, it's a slow problem and it gets a slow response. It's a slow developing problem and it gets a slow response. But for the people actually suffering with it, there's nothing slow about it, right? And yeah, I mean, to me, sure, my academic hat went on if we're bearing our souls about reading this paper, and I thought this is a really low quality study, right? I mean, if I were sitting in a journal club, I would shred this thing as being almost insignificant because we did this thing and this is what happened, right? I mean, who knows how how much of it is true? It could be all of it. Don't get me wrong. I mean, it could be even more powerful than the effects that they found, but it's just you can't say off of this paper, but it still spoke to me as this is a population that's suffering. We don't have great solutions right now. And if people are willing to do the work to investigate new opportunities for improving the health of this population, other populations with PTSD, alcohol abuse, etc., kudos. And I was really excited to see that it was published. I'd love to see somebody pick up the baton and then do some more rigorous work with this. And I don't know, Kristin, to your point earlier, I'd be curious about your thoughts on whether this has to happen in Mexico or Europe or some of the other places where 5-MeO-DMT and Ibogaine are not scheduled as drugs that are illegal and have criminal consequences for their possession or use or sale. Colorado governor signed today psychedelic legislation, which a friend of mine in Colorado sent me as a, hey, did you see this? And I went and I was like, you know what? I've actually never really looked at the Oregon legislation that passed last year. I knew that psilocybin was decriminalized, and obviously the Oregon Health Authority is still working through all the logistics of what that means and what does a treatment center mean and how qualified, et cetera, and who's there. But the decriminalization was for all plant-based psychedelic medications. So Iboga's specifically listed as decriminalized. DMT is specifically listed as decriminalized. 5-MeO-DMT is listed as decriminalized. I'm not sure how they got that one into plant-based because last time I checked, a toad isn't a plant, but whatevs. And
potato.
And it's really explicit. Like, they will not prosecute. They will not enforce federal legislation around it. So I wonder if, I know you've delved into the world of MAPS training and you've got more experience in sort of the formal codified training around psychedelic therapy. Do you think there's an avenue for, Oregon Health and Sciences University or the Portland VA to be able to work with Iboga or 5-MeO, or are we going to still see this happening internationally just because the concerns about decriminalization and the consequences on one's medical license or something from doing these kinds of trials?
So it's an interesting question, because Ben and I have been approached by folks who are very much interested in finding a legal pathway to study at least Ibogaine in our state. And I think that, so I can tell you that there are people trying to put political pressure, and going back to kind of what Ben was talking about, especially engaging the veteran community with some of those political efforts to lobby for legal research in the states, right? So we're sort of saying, look, our special operations forces are traveling everywhere, everywhere else but the states to get some form of help and some treatment. And, many are coming back and becoming advocates and saying how helpful their experiences were, and going to their congressmen and their state politicians. That is not my area of expertise in terms of the legal pathways, but I can tell you that there is certainly, at least we've encountered, and I don't know that we can say too much more about that, but folks that are trying to find legal pathways, at least in the state of Kentucky, to start to do some research around it. So yeah, I'm hopeful that we'll start to see more stateside research. And at the same time, I know that there are some trials with the analog for Ibogaine happening. I believe it was in Spain. I don't know, Ben, if you can recall a phase 2 trial in Spain with an analog of Ibogaine, at least. So we're going to continue to follow it closely and hope to see some more data, better data.
Yeah, a lot of the phase 2 data comes out of Australia or New Zealand, I think. It's legal in New Zealand, so it's been better studied there in recent years.
Right. Well,
I'd rather go to New Zealand than Mexico, but that's just a personal preference.
Sounds like a more fun trip, a little bit of a longer trip, but New Zealand does look super Lord of the Ringsy. Looks like it'd be an amazing place to visit.
Yeah.
Thank you, guys.
Let's go.
This was
I can't think of like a more ludicrous speed level sort of journey to be on than like a 5-MeO DMT / Ibogaine research journey in New Zealand anyway, right?
Yeah. I don't think we're ever getting back on the podcast if we pull that string and see what unravels from there, Ben. But I'm staying out of the 5-MeO Ibogaine New Zealand research study. But you can send me your results, and I'd be happy to peer review for you.
Time will tell.
Awesome. Listen, thank you guys so much. This was a really fun conversation and super interesting. We'll keep our eyes, as we have been doing, on the emerging space of all the new and innovative treatments that are emerging, and we'll definitely reassemble like Voltron when it's time to talk about something new on the podcast. So thank you guys.
Thanks.
Thank you.
Thanks so much for listening to the Wild Health Podcast. If you're a Wild Health patient, you might not know, but you have access to our referral program. This gets your friends and family 25% off Wild Health services. Just head to Clarity, and in the top right corner, you'll see Refer a Friend. Click there, and you'll be brought to a page with your referral code. Happy sharing.